Hi, this is Mai Sargueli of the CPRS Tips and Tricks video series. So this is my first video in maybe a couple of years, and I wanted to post this video because I've actually changed the way that I look at medications, and I wanted to make sure that I put it out there because it's improved my workflow quite a bit. So just as a quick background, I'm an inpatient provider on an academic team. We have a couple residents, a couple med students, and as an academic provider, I really make sure that I grant as much autonomy as the team can get or can handle. So with that being said, during rounds, I don't touch CPRS. I really work very hard to make sure that I walk into the room with all of the information that I need in my hand offline. And obviously, if there's an active situation would be that would require knowing CPRS, then we'll use it collectively as a team. But I really try to make sure that I grant as much latitude to the team as I can. So with that being said, though, I need to make sure that I walk into the room with an understanding of my 10 to 14 to 16 patients and all their meds that they're on, and need to be able to process that in my pre-rounding flow. So my last video, if you haven't reviewed it on meds, I really still recommend it because it goes over a couple different things. It goes over this med tab, and I'm going to skip over that now. I used to use the med tab, but I've stopped recently because I'll show you what I'm using now. But it does specifically go over the BCMA tab, which is here, and it's also up here, and it goes over the graphic tab, which is in labs for historical medication. So if you haven't looked at that video, I'd start there and not here. But so from an inpatient perspective, what I've started doing is I will transcribe all of the data that the patient has that's relevant to my working document, and I use a Word document. I know that some people use note cards that continue on, or whatever else, and so I transcribe all of my information so that I have it offline when I'm rounding on the team. So that includes all medications that are really quite relevant to the admission. I tend not to transcribe some of the PRNs that aren't being given, or that aren't that high utility as I see it, just so I can really focus on the high yield medication. So what I started doing for a very brief period of time was I started using this active medication tab here on the cover sheet, but I found that it was limited in the fact that you could only list about 15 medications. And as soon as you have one diabetic or any patient on a sliding scale, you use about 6 to 7 of those just with sliding scales and dextroses and all that. So you find yourself scrolling back and forth, and then in order to go back and see what they're on from an outpatient perspective, you have to go elsewhere. And so I really found that to be a little bit tricky to use. So what I started doing was I started using this reports, and let me compress the tab. So it looks like this. Your clinical reports tabs looks like this. It's under reports here. And I expand it, and I specifically will go to pharmacy here, and I'll look at all medications for a new admission or for a patient that I'm taking over that has been in the hospital for a week or 2 weeks, or something else along those lines. So I'll go to this all medications, and what it does is it loads up the whole history of all medications this patient has ever been on within the confines of your VA institution. And I'll start out by clicking inpatient here. And what it does is it lists off inpatient and then active. And you can see what's inpatient and active. And then you can very quickly see when it was started, and then the instructions here. And then it's listed here. So like if you're looking for if this is PRN, or if you're looking for if this is scheduled, you can look here. But really, I recommend pairing this view with this med history admin BCMA, and that's in the other video, so take a look at that. But so I'll go here and I'll look, and I know that the most recently active inpatient medications are at the top, and I'll essentially transcribe those, and you can see that I can now have up to 20-30 medications that I can view at a time in a very easy to digest list, and just kind of grab them and kind of process them. Now, what I mean by you can get a feel for what's going on with the med team is if we then, so I'll take a look at that inpatient, and then I'll go ahead and click start date. And I'll just make sure that I'm not missing anything based on from the time of admission to the time that they arrived. So what I mean by that is that you can see this patient has 1, 2, 3, 4, 5, 6 drugs that were released within 1 minute of September 1st, 2020 at 6:45. So this would have been when a package of drugs was released. Think of it like you've held orders and now that's being released from the emergency department to inpatient. What you can then see is you can see in close proximity how drugs were ordered. So if you have someone that, say, gets heparinized and an aspirin and a statin, and those are all being ordered within 3 to 4 minutes or within 1 minute of all those things being signed, you can tell now all of a sudden that someone's thinking that there's maybe a potential ACS event or something else along those lines. So that's what I mean by I can begin to process a little bit what's going on with the team. Now, the other thing that I really use this for is I'll look at active medications inpatient, and then I'll go here and I'll go to outpatient medication. And what this does is this lists off what you expect it to, which is the last fill date. It lists off when the data was issued. It lists off by the drug. So I'll go to here, issue date or expected cancel date, and I'll look through the status and I'll make sure that I capture all the active ones and then potentially any of the discontinued ones and any of the expired ones. Because what can happen is that a patient can have a drug, they're still taking it. It can be not inactive. It can be like, say, expired, but they have drugs and the last fill date was 90 days, was less than 90 days ago, and they theoretically are still taking the drug. And so I'll use this to cross-check my inpatient list to make sure that I'm not missing any drugs that that potentially they were on as an outpatient that they should be on as an inpatient. A lot of the medication reconciliation process that you can do electronically. Now, under no circumstances, and I tell my team this, that does this forego the true medication reconciliation process when it comes to actually going through the medications with the patient, the family member, the facility that they're coming in with. But so that's how I've changed my flow a bit, and I have noticed that this is minimize the number of times that I've had to lean on the resident team to go back into CPRS to check to see if a drug is there, and it's actually sped up my process quite a bit. So I wanted to make this video, put it out there. If you use a different process, feel free to put it in the comments below. But that's how I've started doing it. I just wanted to put this out there. So thank you so much. I really appreciate your guys' time. Have a good day.